All right, good morning. Thank you everybody for coming. We appreciate Dr. Deck and Dr. Tongson coming on this morning to educate us through all these times of the pandemic and epidemic that's going on there. No matter what, we still all were either diagnosed with BRCA or survivors and still need continuous education. As some of us don't have resources to go to the physician's offices right now. Yes, telemedicine, but there's other urgencies, that are ahead of us. So I figured I have two amazing physicians that I follow and read about all the time. And I know Dr. Deck personally from meeting him and watching his work has just been amazing. So at BRCA Strong, we're here to empower, inspire, educate, and advocate women who are survivors and survivors to eliminate the feeling of isolation and help you feel whole again. We do that by funding women post-mastectomy garments. During COVID-19, it's been a little hard for us to go out and actually measure women. So what we've done is go ahead and put some baskets together to send women. Cindy Papali's on the call. She has donated books to us to go out to mail to women with other things in their kits, as well as, inspirational cards, affirmation cards, and just little things that, get you through either your surgery that you're going through right now or your treatment during COVID-19. So again, thank you, Dr. Deck. Thank you, Dr. Tongson, for your time. And I'm going to pass the mic over. Let's see, Dr. Tongson. Perfect.
Hi. Thank you, Tracy. Thanks for putting this together. I think it's a really good way to, keep everyone together while being apart during all this COVID stuff. I'm Dr. Krystina Tongson. I'm one of the breast surgeons with the BRCA Center. I currently practice with Lenox Hill and Upper East Side, Manhattan, downtown and Greenwich Village, Manhattan, and with some possibilities of seeing patients up in Westchester. I'm breast fellowship trained, which means I specialize in benign and malignant breast disease, hereditary genetic diseases, as well as high-risk screening and management. I was trained under the guidance of Dr. Alice Police, who is also one of the breast surgeons that is part of the BRCA Center. She sees her patients in Westchester. She's been in the field for 30 years, and she's an expert, again, in benign and malignant breast disease, breast and ovarian genetics, and she's an innovator in the breast surgery field. So COVID-19. What's going on now with our practice in day, 50 something of quarantine. So COVID-19 has historically changed how breast surgery is being practiced across the country. Our strategies for treatment and surveillance of breast cancer have been changed significantly. And subsequently, it's changing the way we see and monitor our high risk and genetically predisposed patients. So how did we used to do it? We would get our patients, they would find us online or through word of mouth with suspicion through their family history or what they're seeing online and in social media, or sometimes even with a breast complaint. So we'd see them in the office. We would do our intake and our breast cancer risk stratification, doing that with our IBIS calculator. This uses the Tyracusik calculation, which is the newest calculation. Some people may have heard of the Gale model score, which is now antiquated because Tyracusik takes into account a little more things. So what does it take into account? Gyne history that we're all used to answering on almost every intake sheet when we go to the doctor. Questions that we are asked all the time that we usually forget. Age at first period, date of last menstrual period, date of menopause, etc. Tyracusik also takes into account history of breast and ovarian cancer in both sides. So that's what sets this calculator apart. It takes into account the paternal side of cancers, which some people really don't. Well, I'll say most people really don't know, when we're asking patients in the office, what is your family history of cancers? They leave out the paternal side. For some reason, there's this longstanding stigma that just the mom's side matters, but it's both sides. It's everyone, aunts, uncles, cousins, we take all of that into account. Tyracusik also takes into account breast density. We've seen a little bit of a bump in breast cancer risk with increasing breast density, which is what we see which is determined on mammogram. and MRI. It also takes into account history of biopsies and high-risk pathology. So we take all these things into account. We look at the family history, and based on that, we decide on whether or not genetic testing is going to be beneficial for our patients. So the genetic testing that we use is Invitae. There are other companies that do genetic testing, but we've made this good relationship with them, which comes into play later when I get into what's changed with COVID. So the genetic testing is really easy. It's a small blood sample or a saliva sample, and it's a 2 to 3 week turnaround. We do a 47 gene panel that 9 of those genes are taken into account breast mutations or genetic predispositions. And then the rest are, the other questions we ask for for cancer history, stomach, colon, melanoma, brain, soft tissue, and pancreatic. Then, we have our physical exam. We decide on screening, imaging, surveillance, and follow-up. Now, in the COVID area, what has changed? We're seeing patients in our sweatpants, pretty much. So we're starting with seeing patients telehealth first. Most of our staff is working remotely, very contactable via phone, email, and we do most of our paperwork online. We have the information before we meet. If there's a breast complaint, we'll have a secured way to send photos before the telehealth visit. And then we decide on how later of a date can we schedule that physical exam, which is a very important part of, breast surgery and breast disease. We do the same thing with the risk stratification. We do that online. And then at the time of physical exam, we're changing a lot of things in the office. And, this is across medicine, in general, with all specialties. We're going to have limited staff in the office. The waiting room is spread out, we're keeping everyone safe when you do come into the office. We're spreading out times of visits. Unfortunately, we're going to have looser schedules because we want to stagger those visits to limit the amount of people in one place at a time. We're also screening every patient before coming in for COVID symptoms the night before. This way we keep our staff safe, we keep other patients safe, and also we help those patients with symptoms get the treatment that they need. So genetic testing. Now we go through all the stratification, we look at the family history, and we decide on genetic testing. Again, with Invitae now, we have this good relationship where we just put a simple order online and the test gets sent to the house of the patient. That is obviously just a saliva sample, not a blood sample. You don't have to take your own blood. But that's just sent in. And again, the turnaround time is still 2 to 3 weeks. It's not much of that part has changed. So, our main goal right now with COVID and our high-risk patients is keeping everyone safe, but also aware. Being able to contact patients with telehealth and phones has also given us the benefit of having closer and more frequent telephone and telehealth visits. It's a lot simpler versus having someone come all the way into the office. And I'm also working with a company right now to help develop a cancer patient navigation app. This is Ask Zia. It's at ask_ZEA. Her name is Carolina. She's currently working on conducting surveys to better hone in on what the app needs to help patients navigate. And I think it goes along the lines with with BRCA Strong and helping people feel together and supported in such a scary time. I'm also excited about this tool because it can also help our BRCA patients navigate their surveillance, tracking, prevention appointments, and everything like that. So those are the changes on my end. Not drastic, but they are notable. I can turn the mic over now to Dr. Deck, and then we can have questions after.
If you can just repeat the page, it's ask_ZEA.
Yeah.
Okay, perfect.
And so, yeah, so since everyone here, you know, has had their own experience, it would help to get some surveys done to get that app made. So thank
If
you.
you want to connect us after,
I
I'd be
will.
more than happy. And then we can share it on BRCA Strong. I'm sure it's a great tool for everybody to utilize. So if they could
Yeah.
take the time for the survey, I'll definitely share that.
Thank you.
Perfect. Let me unmute Dr. Deck. Perfect.
Can you hear me?
Yes.
Okay, so I am a plastic surgeon. I actually operate from head to toe, so all kinds of reconstructions, but I would say 80% of what I do, so the majority is breast reconstruction, either for prophylactic reasons, for breast cancer. A lot of it is delayed reconstruction. A couple of you mentioned, you know, scars and potentially issues with the quality of reconstruction. So of all the reconstructions I do, about half are actually related to revisions. Broadly speaking, when sort of faced with the decision what to do, a lot of it, I rely on Dr. Tongson to sort of guide me about what are the oncologic requirements, you know, based on tumor size, tumor biology. Some people are candidates for a lumpectomy, just removing the mass. Which is great because the extent of the surgery, the recovery, the hospital stay is a little bit less. Other people require a mastectomy, and then we get into the discussion about reconstruction. And for the vast majority of patients, reconstruction is about choice and just general state of health. So if someone, you know, someone has heart disease and a lot of medical problems, it may not make sense to expose them to additional surgery, which is sometimes staged just because it's too much. But for people who are motivated, you know, to talk about breast reconstruction, it's really about choice. And that includes no reconstruction. For some people, being flat is absolutely the right answer. And I've had patients who are young women and old women who just choose to go flat, and it's absolutely the right thing for them. For those who are motivated to have breast reconstruction, I think of it as two different categories. One is using tissue expanders and implants, and the other one is using your own tissues. And there really isn't a right or wrong answer for you know, what's the best kind of reconstruction, because each one has advantages and disadvantages. But when we decide on kind of a big picture, broad category, it's usually between an implant and natural tissue. When we take someone to the operating room and say we decided on implants, there's a very popular way of doing breast reconstruction with implants called direct to implants. So on the same day, a patient will have their mastectomy and complete the reconstruction. That's usually best for people who have small breasts, so there isn't a lot of redundant skin. And it also depends on the quality of the breast skin. So sometimes I never promise someone that they're definitely getting a direct implant reconstruction, because sometimes in the operating room, when I look at the quality of the skin, I decide it's not the safest thing. You know, the worst thing to do would be to put an implant in and then deal with a wound healing complication, lose the implant, lose a lot of time on the reconstruction. So for those patients, or the patients that maybe have breasts that have, you know, become ptotic, meaning they descended over time with pregnancies, with weight changes, sometimes it's just safer to do it as a two-stage procedure with a tissue expander first. The tissue expander is a temporary balloon that goes on the inside where the breast tissue used to be, and it can go in only partially inflated or even flat, so that the breast skin can heal in a more relaxed way. There isn't that tension on the already, you know, traumatized skin from all the surgery that it's experiencing. And then following a period of healing, we do a series of tissue expansions, which are office visits that allow the expander to increase in size to sort of match the other breast or fit your frame or fit your preferences. And once that's accomplished, we go back to the operating room for a second time to take the tissue expander out and put a definitive implant in, which is much softer, sort of looks and feels more natural. The other category is natural tissue reconstruction. So that's where, that alphabet soup of different flaps, DIEP, SIEA, PAP, LAT, all these different flaps. And there's a number of choices. In my mind, I sort of have them scaled from best, or sort of the one that gives me the best outcomes, which is the DEEP flap, then the PAP flap. But every person's body is different. Everyone's surgical history is different. So I like to have a whole number of flaps in my armamentarium. The flap surgery is a little bit more complex. It requires the transfer of tissue, so skin, subcutaneous fat, as well as the blood vessels that supply the fat. So it's right there, it's a more complex surgery. It takes longer, it takes about 6 to 8 hours to accomplish one breast versus 2 breast reconstructions. And then the hospital stay is a little bit longer. Most patients stay for 2 nights afterwards. So it's signing up for a little bit more than just putting in an implant or a tissue expander. But long-term, the quality of the reconstruction is better. The tissue is your own tissue. It sort of, over time, matures and just looks, feels more natural. Regardless of what kind of breast reconstruction someone chooses, oftentimes there's second stage revisions. So a lot of it is determined by the conversation I have with the patient about revisions and how far they're willing to go to, pursue perfection. People in general who have non-ptotic breasts, so younger women, they tend to be a little bit easier to reconstruct. But for the motivated patient, anyone can achieve a very high quality breast reconstruction. So Dr. Tongson and I did a study recently. Hopefully, Tracy, I'll be able to send you that article in a couple of months about aesthetic outcomes from different types of breast reconstructions. It was a survey of aesthetic results. And we found that for patients who start out with non-ptotic breasts, the outcomes are, the scores are exactly the same before and after. And for the patients that start out with ptotic breasts, correcting that breast ptosis, their aesthetic results were actually better after mastectomy and reconstruction than before, which is really encouraging. It just sort of shows you that anyone who's motivated can have a high quality breast reconstruction.
Great. Well, we'll look forward to getting that article. I love sharing data. So what I'm going to do.
Maybe, yeah.
Go ahead.
I was going to say, maybe we could talk a little bit about what the BRCA Center is and its history. I think. Definitely. The Lenox Hill Breast Center has been in existence for years, over 10 years now. And as part of that, we were just naturally, seeing lots of people with BRCA mutations, like Dr. Tongson mentioned. Sometimes they would come in with a concern, a family history, sometimes actually with a symptom or a mass. We would screen them for BRCA, so we would diagnose new BRCA mutations. Sometimes they came in with BRCA mutations. And I'm not sure what your experience was like, but taking care of someone with a BRCA mutation, it's not just one doctor. It's not, taking care of someone with breast cancer requires a plastic surgeon, breast surgeon, medical oncologist, radiation oncologist, diagnostic radiologist. With BRCA, it's even more because of GYN issues, ovaries, fertility preservation, child life, sort of being able to having guidance about speaking with your children about what a mutation in the family potentially means for them. So in order to really provide comprehensive care for our BRCA patients, we really assembled a team of breast surgeons, plastic surgeons, GYN oncologists, fertility specialists, all these different specialties that work with a network where there's constant flow between the different doctors. So you're not left kind of investigating on your own, you know, okay, now I have my breast surgeon, now I have to find a GYN oncologist. Well, what about my ovaries? What about my hormone replacement? How it's all sort of figured out together, and almost under one roof. All the doctor's offices are very close by. So it's meant to be comprehensive. Right now in the entire United States, there's a center like that in San Francisco. There's another one in Philadelphia. And even though there's high risk clinics all over the city, things like that, we're the first ones to have been named a BRCA center. So that's really exciting.
You know, before you hopped on, I think I was saying, you know, it'd be so imperative if Florida could get one. You know, we have so many cases, so many women like all over the US, but if Florida and all these major states had them, I think that the BRCA mutation or any mutation wouldn't be so overwhelming for people. You know, I remember I was diagnosed pre-Angelina Jolie, right? There was no centers. I went to private practice. I was thrown everywhere. And matter of fact, we were talking today that you're not sent to the right physicians, or you're sent just all over the world when you can just have one center.
Yeah, I think it makes a difference when you're fighting for your health. You kind of want to be in a place where they're not sort of piecing it together, where it's figured out and you're not the first one going through it. It's sort of like a matter of routine, and there's a large level of comfort.
Okay. So what I'm going to do is I'm going to unmute everybody. Thank both of you so much for coming on and speaking and sharing so much information. I know that it's imperative, no matter what part of your journey it is, to always keep up with the education, because revisions are done or somebody you know needs a revision. So thank you so much for both of your time. I'm going to unmute anybody to see. I know I personally have a couple questions. I don't know who wants to answer them or first. So one question that I do have is, for the BRCA mutation, is there a percentage like of African American women, like what their risk is for the BRCA mutation, as well as Ashkenazi Jew descent? Do you know if there's like any numbers that we can have?
It is so for BRCA1, you know, we see a little bit more prevalence in African American women because it's also related with triple-negative breast cancer. Actual numbers, I can get those for you. I can't get them off the top of my head.
If you don't mind.
Ashkenazi Jewish ancestry is also taken into account in breast cancer risk. So that's one of the that Tyra take into account. That usually brings up the risk about 5%, not huge. But I unmuted myself.
Sorry.
Into account the rest of the family history and what sides and the age and what kind of cancers, then that bumps you up a little more.
Okay. All right, I saw Tammy. Who had a question? Everybody just raise your hand because we're hearing a lot of background noise, so I just muted everybody again. Tammy, go ahead.
So I have a couple of questions, two questions really. At the BRCA Center in New York, you know, like one of the biggest things for me when I was diagnosed with, I had ovarian cancer the first time when I was 19. I didn't get diagnosed with my BRCA gene until I was in my, like at the end of my 30s, like 39, 38, something like that. But within that process, I had watched my mother go through cancer, chemo, everything. And it was like very traumatic. Do you guys take into account any of or do you offer psychological support? Because I think there's this level of PTSD that comes with the gene and you're super paranoid about everything. You get a bump on your leg, you think you have skin cancer. I mean, it's just this constant like rest of your life, this anxiety that you're living with, and you're reliving losing people or experience or having the cancer. You know, like I've had ovarian cancer twice before I was like, okay, just take everything, you know? So, I mean.
Definitely. So we do have resources. They're not under the same roof, you know, they're not part of the BRCA Center, but in our hospital system, we have resources for social workers and also an oncopsych program. So there's a screening tool that was sent to us for the breast surgeons and other oncology specialties for a certain practice up here in the Northwell system, up here in New York. And, you know, we give them the tool and, you know, they get a score and they get sent over for this oncopsych program. Now, is it a big national thing yet? No. But in the fellowships now, the breast fellowships now, it's starting to be part of the curriculum to rotate through and see what, you know, those specialists go through and help with. There's also palliative care specialists that we work with. And, you know, that's the word palliative care is a little scary, but what those specialists actually do is they're kind of the ringleader for the care, almost like a navigator, but it's a physician. And usually it's a primary kind of specialty, but a lot of the times it's a psychiatry specialty that mans that. And, you know, we're working on trying to get more palliative specialists on board. We're also working on changing that name because it's you know, there's a stigma with palliative where it feels like, you know, we're giving up on you. But it's the specialty itself. When you start hearing about palliative care specialists, they're actually moving more towards being that person that the patients can go to and ask those questions. You know, if you're, you know, my wrist hurts, is my breast cancer in my wrist? It's someone kind of like that'll bring you back down to earth and help you with that, you know. And Dr. Police and I and the other breast surgeons and as well as our nurse practitioner and our nurse, we're also very reachable to get that phone call saying, is my breast cancer in my wrist? You know, is that itch coming back? Is that what I'm worried about? And then we'll be there to tell you, you know, it's not, and we can see you at any time. So we definitely take that into account with our patients.
Do you guys see a lack of like mental health, like Tammy said, like PTSD, not even from like your family history, but just from like your whole journey of, you know, getting BRCA diagnosed, to taking preventative action, to, you know, I think it's, yes, survivors and survivors have similar journeys of a mastectomy and stuff, but obviously medications and, you know, treatments are different. But, you know, from a mental aspect as well, you know, for both of us, you know, do you guys see a big side of that for the BRCA testing? And
for BRCA testing itself, I definitely don't see, it's definitely a need. Okay. For BRCA testing itself. Now, for after diagnosis, you know, there are protocols in place where we have our surveys at each visit, the surveillance and survivorship program that everyone's supposed to be putting into place to be up to standards. But I definitely see a lack there and a need.
Yeah, there definitely, that was one major question. From my personal experience, I had such severe anxiety, and I'd still, you know, my last surgery, I had so many complications from all of my surgeries, and I'm sitting in the same rooms that I watched my mother die in, like same hospital, same chemo, you know what, it was just the same, it was very traumatic. And I think, you know, and I was able to have one kid, I never had another one. And, you know, there's a lot of psychology, I think, that is, and you're even at, you know, once you have breast cancer and you survive it and you've had your mastectomy, I think for BRCA positive people, it's, well, I've done all these things, but now I can get pancreatic cancer. Now I can get skin cancer. Now I can get, like, what else can I do to stop this from happening? You become almost like paranoid about being, you know, preventing, and sometimes it hinders you a lot. So that was one question. And then the other question was, one thing, and Tracy and I talked about this also, I had a full mastectomy with a latissimus dorsi flap procedure and many complications afterwards. My flap, you know, I don't know if the surgeon screwed up or it failed. I had the full mastectomy, and then one breast, he couldn't complete I forgot whatever it's called, moving the tissue. So I had to go through another surgery for that, and then have, you know, options and all kinds of things that happened. But there was no physical therapy or anything afterwards. So even that, like the surgeons were just like, they came in, I did my follow-up afterwards, but there was no this is what you need to do to exercise this area, it's all still numb and sore, you know, not sore, but stiff. I guess that's the right word. And I was wondering if that's common practice with most surgeons to give you some kind of aftercare. Because I noticed with a lot of the people that have had these reconstructive procedures, there was no real aftercare instructions or you know, physical therapy or anything like that.
Yes. So I think, you know, surgery is probably 80% of the work of the reconstruction is accomplished in surgery. And most people end up doing it in not just one stage. Most breast reconstructions require 2 stages. So it's like a period of your life where you're going through surgery and recovery. But for the vast majority of patients, it's this finite amount of time where it's like a 3 or 6 month period in their life where they're kind of in the middle of it, and then they move on. And although minor complications like a stitch unraveling and dealing with a little delayed healing, that happens not infrequently. Major complications like you described, like losing a flap, are pretty rare. I can think of in my entire practice, I've lost 3 flaps out of, you know, now hundreds, if not over 1,000 patients. So devastating complications like that are pretty rare. At every visit, I do assess people for chronic pain, range of motion issues, and everyone's offered an appointment with a physical therapist. Some people, when I look at them, I just kind of can see that their full range of motion is back. They don't really need it. Other people get a little bit of stiffness. And it's the kind of thing like if anyone were to be put into a cast for 6 weeks, when the cast comes off, you know, your hand is stiff. The same thing happens after breast surgery where you're nervous, you're splinting the area, you're intentionally limiting your activities. So when you get the all clear that you can resume activities, your shoulder may be stiff. So people who do feel stiffness will see a physical therapist. Now, there's all kinds of physical therapists. You know, if you Google them, there's one, you know, in every neighborhood in the city. But breast physical specialists are kind of more specialized and rare. They can do lymphedema therapy, so they can do a lot. And we work with a couple of them.
Yeah, we do. We definitely.
I just thought it was strange that, you know, my hospital didn't do it. Didn't recommend it, didn't even talk about it. It was just like, you're out of here, you know? That was Memorial.